right, well, thank you very much to everyone for the invitation to speak here. It's great to be here. Let's get started. If I was giving this talk about 10 years ago, this is what I would have showed you, okay? ACD combination, that's really all we had. Then about 10 years ago was the Pathway 2 trial, and we know that spironolactone is next line therapy for resistant hypertension, and that's sort of where we were. There was some stuff on the edges. What we know, particularly in the last about 5 to 7 years, is that hypertension care, which is incredibly, hypertension is incredibly prevalent, but it's really had a renaissance because we're understanding that we're not doing a good job treating it. And I would argue that that right now is not good enough for us, and the data would support that. If you look, these are the circulation AHA statistics that are published every year, and unfortunately, this chart does not change very much, okay? On the left side, we see control rates of hypertension, and this is to a 130/80 or less definition, and we're less than 30%. And it doesn't matter if you're Black, white, Hispanic, Asian, although there's small differences. We do a poor job of controlling blood pressure in all those groups. We do a poor job in elderly and younger people as well. So we need to move the needle a little bit. And so the overarching question that I asked myself as I was coming up with these top 10 was, and I want you to think about it as I talk, is how can we more effectively control blood pressure in our patients and more globally in our communities? So here's the hypertension top 10 list. I won't read them all right now, and this is not in no particular order, but I think it's really important, and I'd like to touch on as many of these as I can over the next 25 minutes or so. So many of you know that very recently, back in middle of August, American Heart Association, American College of Cardiology, multi-society blood pressure guidelines were released. And a great document, worthwhile looking at the key points. It was a little bit iterative in how it was presented. There wasn't any huge changes, but I'd like to highlight a couple, okay? Number one, and this is something that we can really practice every day with our patients in clinic, is although many of us are trying to get them less than 130, which is what we've done, there's new language that's highlighted here, with encouragement to achieve a systolic blood pressure less than 120 millimeters of mercury. And this is building upon data from SPRINT, which targeted a blood pressure of less than 120, but only achieved 121 for systolic blood pressure. But more trials have shown that the lower the better in terms of blood pressure reduction. And this doesn't matter if your patient has or doesn't have diabetes. We know that this should be achieved if reasonable, if we're not adding a fifth, sixth medicine and getting into side effects. What we also know is, this is a little bit more clear, that patients with stage 1 hypertension, we want to give them about 3 to 6 months to do the lifestyle, but really don't kick the can down the road, or don't let them kick the can down the road any further. After that, we need to start thinking about medication choices in these individuals. What I think was something that is really actionable with our patients right now is it's now a class 1A recommendation that the treatment of blood pressure prevents mild cognitive impairment and dementia. And I like to refer to this as sort of the fifth finger. So when I'm talking to my patients, and we start really broadly, and we say, well, why do we want to treat your high blood pressure? We want to prevent kidney disease, strokes, heart attacks, heart failure, and now I've been able to add that fifth finger, dementia. And I'm probably not surprised that most people perk up, okay? We have good treatments for, heart disease. I mean, we just heard about great treatments for heart failure. We don't have anything for dementia. And so, as was alluded to earlier, this gets people talking and thinking, yeah, my aunt had dementia. I don't really want that. So how can I be more aggressive, more adherent, all those things? All right, so those are some of the big things with the guidelines. Some other changes are sprinkled throughout the other top 10 points. The next thing that's really important, and even as cardiologists, we need to be doing this, is really testing patients for primary aldosteronism and dysregulated aldosterone. This is seminal work from back in 2020, looking at 4 major hypertension centers and looking at the prevalence of excess or autonomous aldosterone production. And this is even amongst patients with untreated normotension, about 11% had primary aldosteronism. And if you go up to treated resistant hypertension, that's approaching 25%. And then in between for those untreated stage 1 and stage 2. So we know autonomous aldosterone production, otherwise that are branded as dysregulated aldosterone production, is prevalent, and we need to be recognizing that in our patients. This was really more prominent in this set of guidelines, okay? Everyone with resistant hypertension, irrespective of if they have hypokalemia or not, should be screened for primary aldosteronism. That's very clear, and that's with just an aldo and renin, okay? We do not need to stop medicines in this scenario as well. The only ones that we should stop for about 4 weeks, at least for the initial screen, is going to be spironolactone or eplerenone, our MRAs. And then importantly, although it's only a 2B recommendation, is they say you can consider testing all patients with hypertension for primary aldosteronism because it is so prevalent. This backs up other guidelines. Now, this is from the Endocrine Society, which were published in July of this year, and this is their primary aldosteronism guidelines. They advocate, as well as the ESC hypertension guidelines, for screening all individuals with hypertension for primary aldosteronism. And then there's a nice algorithm there about how that we actually think about it once we get those data back. And so as cardiologists, if this is all you really have to do, and then send it to a hypertension specialist, send it to an endocrinologist, but at least if we're looking for it, if we're not looking for it, we're never going to find it, and we're not going to be able to treat patients effectively. All right, number 3, single pill fixed dose combination therapy. This is, we do a horrible job at this in the United States. They're better in Canada, better in Europe. It's very clear. The data is clear. People don't take multiple pills. They don't want to take multiple pills. They may if they have heart failure or something that severely impacts their quality of life. The vast majority of people, hypertension, particularly sort of long-standing, doesn't impact their quality of life until they have a stroke or heart attack. It's a silent killer. I mean, we talk about our patients all the time. So we need to be starting patients that are 140/90 on fixed, single pill, fixed dose combination therapy. That's pretty clear. Now, those individuals with stage 1 hypertension, you can start with a single antihypertensive drug is reasonable, but now American and European guidelines both align with saying we should be on, amlodipine benazepril or amlodipine olmesartan, some combination if we're in that 140 or greater blood pressure range, and so important to understand that. We also know that we're moving away from the inertia of thinking that these drugs and combinations are expensive. They are not. One of our residents at Cleveland Clinic did this and looked at the cost of these drugs at Mark Cuban's Cost Plus Drugs or GoodRx. These combinations are not that expensive, okay, when you look at on a 30-day. And so they're widely available. And there's even some 3-drug combinations. One that I'll point out, and it's not clinically available yet, but these studies have been done, and they're looking to launch by the end of this year or early next year, is a really exciting triple combination of amlodipine, telmisartan, and indapamide. And if you're not familiar with, one of the downfalls of some of the combination pills is most come with hydrochlorothiazide, which, as you know, is our weakest thiazide-type diuretic. This comes with indapamide, which is a little bit longer acting, closer to a 24-hour effective half-life rather than the 16 to 18 hours of hydrochlorothiazide. And we don't really know what the pricing is going to be, but when you talk to the company, they're trying to aim in that sort of that $30 to $40 per month. So that's not going to be for everyone, I'm not saying, but it may be an option for some individuals if they're paying, $14 to $16 for, 3 separate pills. Would they be willing to pay, $30 to $40 for just a single pill once a day? So that's called Widoplex, so as a brand name. So keep an eye open for that. All right, number 4, renal denervation. It's been a long journey for renal denervation. I'm not sure if Dr. Bott is still in the audience, but he knows sort of the real ups and downs of this. About 10 years ago, renal denervation had a major shift because of the neutral endpoint for simplicity HTN3. Then there was a lot of time, a lot of energy, a lot of money invested into saying, well, why didn't those trials work, and what should we be trying to do? And I think a real big milestone in renal denervation these days is now it's in the guidelines. It's a class 2B recommendation that in carefully selected patients, renal denervation can be considered. This guideline was very conservative in how it looked at renal denervation, so it recommended very strict criteria based on the trial criteria. So 140 systolic and 90 diastolic have to be higher than, and you have to have a GFR over 40, and you have to be on optimized medical therapy, which if you delve a little bit deeper in the text was 4 drugs and uncontrolled, so including those patients on spironolactone, not your true definition of resistant hypertension. And so you have the list there of some of the contraindications, but we're doing it more and more frequently at Cleveland Clinic, and it may be something that, that's important down the line as we get more data. One group that I think is underappreciated with this are the patients that, you go into their medical chart and they have about, 20 allergies. They take their losartan and their toe hurts and they're not going to take it. We know and we see this, and irrespective of whether the side effects that they get from drugs are, if they're real or they're perceived, it doesn't matter because they're not taking the drugs. So this is an opportunity for us to get, roughly about 1 blood pressure medication worth of blood pressure lowering in these individuals in a single, same-day procedure. Beyond the guidelines, so CMS has a national coverage determination out for renal denervation. This was a placeholder slide that I was supposed to update October 8th because the final decision, they go through all the draft comments and everything. However, we still don't have that because of the government shutdown. But I expect soon, once that government, when things open up again, we'll get the final coverage and see how CMS is looking at it, what and how it will be covered nationally. And it was generally a pretty favorable statement initially. Also, renal denervation, the next generation of renal denervation is not just looking at denervating the renal arteries, but also the hepatic artery as well, and seeing can we have improvements of cardiometabolic risk factors such as hemoglobin A1C, insulin sensitivity, et cetera. So those are pilot trials, but more to be determined and to come in that scenario. All right, aldosterone synthase inhibitors is number, I think it's 5. We know, and I alluded to it earlier, that aldosterone production is bad for most organs. Excess aldosterone production is bad for most organs. And we know that you don't have to have overt primary aldosteronism to have high blood pressure due to autonomous aldosterone production. We can see this really in primary hypertension as well. Aldosterone synthase inhibitors are a new class of medications, and you don't have to take my word for it. There's a lot of people that think that these are really a success story and really the next generation of very effective blood pressure lowering drugs. What is an ASI? Well, essentially it disrupts aldosterone biosynthesis, and it's different from a mineralocorticoid receptor antagonist, which blocks the mineralocorticoid receptor where aldosterone binds to. Prior generations of this, what they weren't is they weren't selective for what's CYP11B2, which is on the bottom left-hand corner of that picture. And so they also inhibited CYP11B1 and decreased cortisol production. We know with these newer generations that they're more selective, much more highly selective for CYP11B2, reduce aldosterone production, which without impacting the cortisol axis. And that's why there's a lot of industry development in this space. So here's the overview of really 4 drugs. They're being studied for a variety of indications. Dexfadrostat on the bottom left, really the major that it's been tested in is primary aldosteronism. Baxdrostat and Vicadrostat are being studied in heart failure as well as kidney disease. Vicadrostat is not looking at the hypertension angle of things, so I'm not going to talk about that. Baxdrostat has looked at hypertension. We'll go through that. And then lorundrostat, at this point, has been studied in hypertension, CKD, and interestingly, an ongoing study in obstructive sleep apnea as well. So what are these data? So these were presented at ESC just back in August. This was the BAX-HTN trial, pivotal regulatory trial of baxdrostat compared with placebo at 2 doses, 1 and 2 milligrams. And it was 12 weeks, double-blind, placebo-controlled. Office blood pressure was the primary endpoint. And what was seen was anywhere between about an 8 and 10 millimeter of mercury reduction in terms of blood pressure. And that's placebo subtracted. And so very promising in this scenario. BAX24, which is their 24-hour ABPM study, is going to be presented at AHA in a few weeks. Advanced HTN, this is near and dear to my heart, many years with this. This was presented at ACC last year, published New England Journal in April of this year. This was the phase 2B of lorundrostat, so another ASI, looking at 24-hour ambulatory blood pressure changes. And as you can see here, placebo-adjusted change was between 6 and 8 millimeters of mercury in 24-hour ABPM. Now, it's important to remember, comparing office and ambulatory or 24-hour ambulatory, you can't look at it sort of one for one or similar. Typically, ambulatory blood pressure reduction is less than what we see in an office setting. Now, this was an interesting trial in that we put patients on a standardized regimen. And so it wasn't just usual care. We maximized what they were on and then added lorundrostat. Subsequent to this was the pivotal phase 3, which was office blood pressure on the background of usual care compared with placebo, and very or strikingly similar to the baxdrostat data, right about 9 millimeters of mercury in systolic blood pressure reduction. And it didn't really matter any of the other factors, all the subgroups looked good. So what is needed to support its clinical use? Well, these really. We've got upper left-hand corner here. One thing that we haven't seen, and we probably won't see from industry, is head-to-head compared with spironolactone. But, let's see. Let's to be determined there. All right, next, angiotensinogen-directed therapies. These are exciting. Angiotensinogen is really the top of the renin-angiotensin-aldosterone system. Can we modulate those levels and actually reduce blood pressure? Let's see. This is an increasingly crowded space, so we will get that answer, okay? There's a variety of siRNAs, and there's one antisense oligonucleotide that's being studied as well. The one that has far and away the most data are the zilebesiran trials, which were alluded to last time as well, and so we'll talk about those. The phase 1, that was in New England a few years ago. The Cardia trials, 1, 2, and 3, have all been published within the last couple of years, or at least presented. And then really what the big plan there is, though, is a cardiovascular outcomes trial with zilebesiran. Here's Cardia 1. This was phase 2 on the background of no blood pressure medicines. And what was seen was a placebo-subtracted 24-hour ABPM reduction of about 15 millimeters of mercury across a variety of doses, okay? When you got into looking at it in the background of a single drug, so either in combination with indapamide, in combination with amlodipine, or in combination with olmesartan, you see that not surprisingly, a little bit more efficacy in combination with the diuretic, a little bit less with an ARB, about 5 millimeters of mercury. And just one thing I neglected to say, these are subcutaneous injections every 6 months, like most siRNAs. So interesting. Now, Cardia 3, which was also phase 2, was just presented at ESC. I won't spend a lot of time on this, just saying that the results for it were a little bit underwhelming, okay? The way they did the statistical analysis, it actually wasn't significant with either dose, but the company pushes ahead. And the Zenith trial is their cardiovascular outcomes trial that will randomize patients 1-to-1 to placebo or zilebesiran and see how they do from a 4-component major adverse cardiovascular events. So we'll see. But that's coming out, and that's potentially a long-acting once every 6-month drug. Tonlamarsen is a once-a-month subcutaneous ASO suppressing drug, AGT suppressing antisense oligonucleotide, and this is being studied in the Cardinal trial, and that will be wrapping up relatively soon here. And so we'll have could it be even safer than an every 6-month? We'll see. We'll see what the future holds too. It's publicly available knowledge. We've heard a lot about CRISPR-Cas9 therapy today. CRISPR Therapeutics has publicly announced that they're going to do gene editing trial for AGT and see what that is. Maybe we can give a one-and-done injection to these folks, or infusion, excuse me. We will see. All right, incretin-based therapies. We know that obesity-associated increases in blood pressure, there's a lot of reasons why blood pressure increases with obesity, and all these mechanisms operate simultaneously. We also know that there's relatively inconsistent effects of a variety of prior blood pressure, or excuse me, weight loss drugs in reducing blood pressure, but definitely with semaglutide, we do see more than we've seen with other classes of obesity pharmacotherapy. Interestingly, the SURMOUNT-1 trial, which was tirzepatides and one of those key weight loss trials, showed that even among patients with a baseline of 123 millimeters of mercury of systolic blood pressure, you saw about a 7 millimeter mercury drop in office. There was an ABPM sub-study looking at 600 of those individuals, and you saw really sort of similar and even more robust results, about a 10 millimeter mercury reduction in ambulatory blood pressure with tirzepatide 10 milligram dose. And that, again, was consistent across a variety of subgroups. One thing that I've been interested in for a while, and I'm happy to lead these trials, they're called the ATTAIN hypertension trials, looking at the small molecule orforglipron, which is an oral GLP-1 receptor agonist. And what these are looking at is, can this drug lower blood pressure, okay? We know it lowers weight, but what does it do to blood pressure? Are there other mechanisms by which it can work? So we'll see. And interestingly, in the guidelines, they say that GLP-1s may be effective as an adjunct to lower blood pressure, and it's a 2B recommendation. All right, additional new mechanisms to lower blood pressure. There's been a few recent high-profile negative trials. Aldosterone in its Clarion CKD trial failed. There's a really interesting piece on Fierce Biotech is, I guess, on a website about that and recently, so I encourage you to check that out. There was XXB750, which was an NPR1 agonist that failed, but there's new other therapies in the pipeline as well. PDE5 inhibitors for hypertension may be an option. Modified atrial natriuretic peptide drugs may be an option. And actually, I was talking to Dr. Aldabi, who runs the Hypertension Center here, and I think at Mount Sinai, you're going to be a site for that, so that's interesting. What about wearable devices for blood pressure management? Well, the guidelines were pretty clear. It's a class 3 recommendation that there's no benefit among patients for using this. But that hasn't stopped companies. Apple actually released shortly after that, telling us that now our patients are going to use their Apple Watches to get hypertension notifications. Now, I will give them some credit. They are not giving patients a number, okay? That is fraught with a lot of obviously legalities, but also accuracy issues. But what they're going to do, not dissimilar to atrial fibrillation, is they're going to features on that, is they are going to give patients a warning and say, you may have hypertension based on this. Now go down this pathway of checking your blood pressure at home with a validated device, and then talk with your clinician about what you should do next. So be prepared for a few MyChart messages about that. All right, in my last 2 minutes, I still want to touch on the fact that the basics still matter, and that's point number 10. We have all kinds of new therapies. We talked about renal denervation. We talked about all these new fancy drugs, maybe even gene editing as well. But whereas I tell my patients, lipid management or lipids in general, the levels are about 70-75% genetic. The rest are lifestyle. Hypertension's the opposite, okay? What we're at is we're looking at about 70% lifestyle, 30% medications. And so what I really emphasize to all my patients is that the same or very similar tables have been produced in every guideline for the past 25 years in terms of blood pressure. Saying if we reduce weight, if we exercise, if we eat a healthy diet, including low sodium, we are going to lower blood pressure. I try to give my patients a chart like this every time I see them, and this is how much blood pressure is lowered with a lot of these interventions. Low salt diet's worth about 1 blood pressure medicine or 1.5 in most people. I even tell them, and a lot of times, your ARB that you're taking, it's not going to be nearly as effective if you're overdosing on salt. So just something to keep in mind moving forward is we got a lot of new fancy tools. I'm excited about the future for hypertension, but we still have to get back to basics with our patients. And it's surprising, even when they've reached the level of seeing a cardiologist or a specialist in hypertension, a lot of them are not quantifying how much salt they're having, et cetera. So the last point I'll leave you with is that hypertension in particular, because it is so prevalent, because over half the US population has hypertension, just physicians, just clinicians, we can't do it alone, okay? It needs to be a team sport. We have to engage our dietitians and nutritionists. We have to engage pharmacists, physician assistants, nurse practitioners, the whole team there, and then even exercise physiologists as well, if patients have access to that, to really help lower blood pressure. And so with that, hypertension is complex. There's not just one mechanism. We need to do a better job treating it. New medications and renal denervation are important new developments, but the basics still matter. Thank you very much, and I'd be happy to take any questions.
Fantastic. So the questions are already here. Now, what are your thoughts on the lack of emphasis on isolated systolic hypertension and the elderly population in general in the current hypertension guidelines?
Yeah, I think that, we can sort of cut the data from the renal denervation trials a lot of different ways. When we think about isolated systolic hypertension, some cuts show that it is beneficial. Some emerging data, particularly registries, now that it's clinically available, suggest those patients, because some of that hypertension is just driven by arterial stiffness and not an underlying sympathetic activation, that they may not derive as much benefit. And that may have been one of the challenges with the earlier renal denervation trials too, was that inclusion criteria was so broad.
Okay. Then is it acceptable to use Aldosterone every other day with an ARB to minimize hyperkalemia?
I think that if that's working, I think that would be reasonable, right? I mean, I think that we know that spironolactone raises potassium a pretty significant amount. We thought that maybe the ASIs would negate some of that effect. That really wasn't borne out in either the baxdrostat or lorundrostat trials. There was still an increase. But I mean, I think that in certain circumstances, I will dose, spironolactone Monday, Wednesday, Friday, for example, and that can help patients.
And actually, the other question really, which bothers me also in the office, that how do we really diagnose white coat syndrome? Patient comes in the office, BP is 180 to 200. Patient brings the records from the home, blood pressure is always 120, 140. What do we do?
Yeah,
very common.
Incredibly common. What I tell my patients is I do not put any stock in the office blood pressures. And I tell them it's not because they're inaccurate. They're very accurate. Our team is very good and well trained. However, we know that out of office blood pressures are the key, okay? And so I give everyone a handout. There's great resources on ACC.org about that, about how to measure blood pressure accurately at home and different ways to do that, in the morning and occasionally at night, before medicines, et cetera. And then the definitive test is a 24-hour ambulatory blood pressure monitor if you really want to get down to it. But I don't put a lot of stock in those patients that just have elevated blood pressures in the clinic. And I definitely wouldn't treat them more aggressively unless we have corroborating data for high blood pressures at home.
But let me ask you, is not that bad that even if under the stress pressure is 200, it's still bad, right? I mean, it is in the office. I know they're under stress, but then they are they're driving the car. There is a congestion. There issues happening on the road. The pressure is still high. So does it matter whether it's in the office? You got a blood pressure of 200.
So the data would suggest no, it doesn't, but there's a caveat to that. So in patients with white coat effect, so that means elevations in the office, but treated hypertension at home that are controlled, they have no difference in their outcomes compared with people with just controlled blood pressure at baseline. However, patients with white coat hypertension who don't have an underlying diagnosis of hypertension, so they're not treated and not checking at home, they do worse. And the thought process behind that is that then we always say, oh, it's just white coat hypertension, don't worry about it. And we don't actually get them to track their blood pressure more regularly outside the office. So we know that at some point, most of us in this room will transition to hypertension, and the out-of-office blood pressure is what really predicts cardiovascular risk if we're checking outside the office.
All right. So I think we learned a lot in this field of hypertension.